This lecture is going to be devoted to scoliosis and leg length discrepancies. Now you can really get lost in the weeds by trying to learn how to calculate the Cobb angle and figure out the exact reasons for why one leg is longer than the other, and yada yada yada. We're going to keep this focused on what you need to know for the osteopathic side of things and how you can help your patients if they have scoliosis or some sort of leg length discrepancy. So we're going to start off with naming scoliotic curves. There are two scoliotic curves that you can have. If it's convex to the right, this will be a dextroscoliosis. This is also the most common kind of scoliosis. If it's convex to the left, it's a levoscoliosis. Left, levo. So what does this look like? If I'm going to draw out a dextroscoliosis, your vertebra will look something like this. Maybe not as intense of a curve, but something like this. The convex side is the curvy side. We have it pointing to the right, so this is a dextroscoliosis. If it were pointing to the left, it would be levo. One way that you can tell this is dextroscoliosis, if you can't remember convex in what direction, this kind of looks like a D from the posterior side. So what about the severity of scoliotic curves? So there are three different classifications that you need to know. You can have mild, you can have moderate, and you can have severe. So how do we calculate these different severities? How do we know? Well, it's going to be the angle of the curve. And how we're going to calculate that is by using the Cobb angle. We're not going to go over the exact mechanism of how to calculate the Cobb angle. Just remember that you take the angle of the top of the curve and the bottom of the curve, and this is going to give you the angle of severity. So in our chart, a mild severity angle will be 5 to 15 degrees. Moderate severity will be 20 to 45. And severe will be greater than 50. If you have a curve of greater than 50, you need to start worrying about respiratory issues. And if someone has a very severe curve above 75 degrees, you need to start thinking about cardiac issues. So what are we going to do to treat these dysfunctions? It's going to change depending on the severity. So if you have a mild scoliotic curve, you can treat it with OMM. So what exactly am I treating? You can be treating the spine for flexion, extension, side bending, and rotation dysfunctions. What about for moderate? Well, moderate, you can use OMM, but you also need to start thinking about bracing. Not going to go into the details about bracing, just know that as you move down the scale, you need to start doing more treatments than just OMM alone. Once you get down into the severe category, this is when you start needing to think about surgery. You can also have two different types of curves. You can have a functional scoliotic curve and a structural scoliotic curve. For functional, this means that as the patient is moving their spine, as they start to rotate, side bend, and even flex and extend throughout normal motion, the curve seems to go away. So as they curve towards the lesion or towards the curve, then the curve will start to be less noticeable. This is known as a functional scoliotic curve. So away with motion. So you can also have what's called a structural scoliosis. This is basically the opposite of functional, where it doesn't go away no matter how the patient moves. So it doesn't go away. So bringing this back to an osteopathic focus, what about treatment for the patient? Well, if you're going to treat with OMM, you certainly need to look at the spine. But then here's where the main concept of this lecture comes in. You need to understand something about compensation. Now, the body always wants to try and stand up as straight as possible. But if the patient has a curve in one direction, the body doesn't want them to be walking around with the curve. It wants to compensate so that they can try and stay as straight as possible. This compensation pattern is going to cause numerous dysfunctions throughout the body. It's going to look something like this, where imagine the patient has a scoliotic curve, but the rest of the body is going to need to compensate in order to stand up straight. So the anonyments will have to move around. The lower extremities will have to move around. Even the shoulders might have to move around. So with this artist rendering of common compensation patterns, you can see that because the curve is in one direction, the shoulders are going to have to compensate in the other. The neck is going to have to compensate in another direction. The pelvis is going to have to compensate, and even the lower extremity will have to compensate. This is all to make the body stand up as straight as possible. The primary points that you can think about are going to be your anonyments and your shoulders. The big deal that you need to understand is that they cannot compensate in the same direction. If they compensate in the same direction, the patient won't be able to stand up straight. So you see that the spine is to the right, the shoulders are going to have to compensate to the left, while the anonyments are going to compensate the opposite direction of the shoulders by going to the right. So the compensatory pattern is opposite, going up and down the body. So when you're performing your OMM treatments, you need to be looking at different portions of the body in order to treat the entire patient. So not only do you need to be looking at the spine, you can also look at the neck, shoulders, the psoas, anonyments, the sacrum, and the lower extremity. So you need to treat the entire patient, so you need to look at all of the common compensatory areas in order to do so. So shifting gears from scoliosis, we're going to talk about leg length discrepancies. So imagine that you have a patient who comes in whose one leg may be a little bit longer than the other, or one leg's a little bit shorter than the other. Their whole body is going to have to compensate in order to keep everything upright. So the same idea is going to hold true as in scoliosis. The body still needs to compensate, but the cause is different. Instead of scoliosis, it's going to be a leg length discrepancy. So you can have two different types of leg length causes. You can have congenital, which someone is born with, or you can have acquired. So what are some examples of acquired leg length discrepancies? think back to some of the lower extremity and pelvis lectures that we talked about, and you can think of some of the reasons that would cause some discrepancies. Some causes of a short leg can be a posterior innominate rotation. So remember, for a posterior rotation, the pelvis is rotated posteriorly, and it's going to pull all of the bones of the lower extremity up, and that's going to cause a short leg. Now imagine a up shear. If you have a pelvic up shear, one of the innominants are moving up, which is then going to pull all of the bones of the lower extremity up with it, thus causing a short leg. And finally, psoas. The psoas is hypertonic, and it's causing flexion, side bending, and rotation towards one side. The rest of the body is going to need to compensate, and to do that, it's going to pull this leg upward, and you're going to have a short leg on that side. So what about some causes for long leg? As you can imagine, they're probably going to be the opposite of short leg. So you can have an anterior innominate rotation. Remember, when you rotate anteriorly, the bones of the lower extremity will be pushed downward. And you can have a down shear. When the innominate is pushed downward, it will push the rest of the bones of the lower extremity downward, thus causing a long leg. So how about treatment? Well, the first thing that you can look at doing is OMM. If it's some sort of acquired discrepancy, you can just treat the dysfunction like we went over in previous lectures. You know how to treat innominate rotations, and you know how to treat shears. You also know how to treat the psoas. So just do that, and you can potentially treat the leg length discrepancy. But if that doesn't work, you want to start thinking about heel lifts. Now, as we discussed earlier, if the patient has a short leg, the rest of the body is going to compensate for that. You're going to have compensatory patterns throughout the body. When you're treating with a heel lift, you can't just give everything back all at once, because the rest of the body is still compensated. So even if you fix the leg length discrepancy, they're still going to have pelvic dysfunctions, shoulder dysfunctions, neck dysfunctions, everything. So you need to start slow and work your way forward. So you start out with a 1/8 inch heel lift. You increase this by 1/8 of an inch every 2 weeks. This is a little bit different for elderly individuals. For elderly, you're going to start with a 1/16 inch heel lift. Now think about it this way. Granny's not as spry as a college kid, so the body compensatory patterns will take a little bit longer to adjust to changes. So if you give them 1/8 of an inch heel lift, the rest of the body may not catch up as quickly as someone in college. So start even lower and go even slower. So you'll start out with a 1/16 heel lift, and you'll do the same where you increase every 2 weeks. Now this is different for trauma cases. So in this example, by trauma, I really mean fracture. Let's say that the patient has a femoral fracture, he has to go into the operating room and have it repaired. When he comes out, he now has some sort of leg length discrepancy after the repair. If that's the case, the body has not had time to compensate, and you can give them their entire discrepancy back in a shoe lift. This is okay because since the rest of the body has not had time to compensate, if you start out slow and work your way slowly up, the body will have to compensate. But if you just give them their entire discrepancy all at once, then the body will remain normal as it has been. So in this lecture, we went over scoliotic curves, the different severity types, really had to focus on different compensatory patterns and common areas that you can find compensation, and then we went over leg length discrepancies and shoe lifts. And that's OMM for scoliosis and leg length.